All right, so I guess we'll go. All right, so I think we're a few minutes after the hour, so we'll get started. We have until about 3. So I'm Hank Meyer, and this is Dr. Jennifer Newitt, who's from Pittsburgh. I'm from Pittsburgh, but I don't practice here. So we're going to talk about pediatric and adult issues related to hypoventilation or respiratory insufficiency. And we're presenting sort of complementary issues, with me focusing obviously on pediatric issues and Dr. Newitt on adult issues. So with that, we'll move forward. So, it's just, need to, no, yeah, this one right here. All right, so here are my disclosures. None have to do with RYR1 myopathy or the topic. So this is what I'd like to talk about over the next 25 minutes or so. Talking about why do we even worry about hypoventilation? I think we all know the answer, but we'll go into that a little bit. Then what actually is hypoventilation, when to look for it, and then how to evaluate for it, because there are a number of different approaches. So why is diagnosing hypoventilation important? And this is a slide from a paper that was done a number of years ago in Newcastle, UK. And what they did is they looked at, it's a retrospective study looking at patients with largely Duchenne muscular dystrophy, looking over different epochs in time. And so going from left to right on the graph there are patients that passed in the 1960s, 70s, 80s, and 90s, and looking at the survival curve. And so the way you look at this type of a curve is go to the 50% line right here and sort of draw over. And what you can see is that the 50% survival rate got further and further later and later in life as time went on, which is what you would expect from advancements in care. And then what they did in the patients who passed away in the 90s, that was around the time that we were able to do non-invasive ventilation, the stuff that we are do very commonly right now. And what they did is they teased out the patients who had non-invasive ventilation from the patients who weren't supported with non-invasive ventilation. And that created 2 more lines. And the line that's further out to the right are patients in the group that passed in the 90s who were on non-invasive ventilation. And so you can see that contributed substantially to survival, pointing out that obviously if you provide adequate non-invasive support, you can extend lifespan really irrespective of what the condition is. So what is hypoventilation? Simply put, it's underventilation, and it's due to one of 2 things: an inability to breathe deeply, or an inability to breathe enough to meet the body's needs. And so we talk about the combination of those in terms of minute ventilation, which is the amount of air that you're able to move through your lungs in a minute. And that's the tidal volume, or the size of breath, and the respiratory rate. There are other issues that can happen. Pharmacologic suppression of breathing, so after anesthesia, often takes patients some time to waken up and be able to breathe normally. And then acutely, you can certainly have problems with acute muscle weakness during sepsis or an acute infection. And then chronically, in patients with neuromuscular disease, the muscles can become weak enough so that you're not able to generate an adequate breath. And then if you're not able to sustain a higher respiratory rate, then you end up retaining carbon dioxide. And when that happens, you have what we call hypercarbia, and that can progress to having low oxygen or hypoxemia also. And so with all that, you can say, well, when should you look for hypoventilation? And we have some reasonably good natural history data in Duchenne, so that'll be a plea to, if you are willing and able to participate in the natural history study they're doing at the NIH. This gives us an opportunity to learn more about a condition. And so what we know in Duchenne is that patients start out with a normal lung function, and then gradually over time, usually at around 10 years of age, they start to lose lung capacity. And then there are a number of different stages of progression that we see, starting with an increased incidence of respiratory illnesses, general colds, and then illnesses that require inpatient hospitalization, and then getting to the point where patients begin to have nocturnal or nighttime hypoventilation and need nasal ventilation support, and then to the point where patients have diurnal or daytime ventilation and have hypoventilation and have need for continuous ventilation. Then we have interventions through each of these. For patients that are having difficulty with respiratory illnesses, we can use the cough assist. And then when patients are getting to the point where we would worry about hypoventilation, we'll get a sleep study or a measure of nocturnal nighttime carbon dioxide. And then if we have concerns about daytime ventilation, then we can measure the carbon dioxide during awake time in the clinic. And each of these would prompt an intervention. So the typical approach for evaluating for hypoventilation is doing a sleep study or polysomnography. And this is an example of some of the data that we get. I'm not a sleep doc, Dr. Newitt is, and so I'm stepping out of my zone a little bit here. But one of the things that we want when we do a sleep study is we want to have the patient go into deep REM sleep, which is where all the muscles relax. And that's where you're more likely to underventilate, to underbreathe, because you're in a very restful stage. And what will happen is that you'll have a series of monitors on your head to measure your brain activity, and that will be able to show when you're in deep REM sleep. And so here, the sleep technicians will record the times when the patient is in REM sleep. And then what we'll do is we'll look at different outcomes, such as apneas, which is where you have a complete cessation of breathing, or hypopneas, which is where you underbreathe and have a decrease in airflow of about 50%. And then where the money is right here. This is the carbon dioxide tracing, and I struck a line at 45 millimeters of mercury, which would be the upper threshold of normal. And so you can see during that time, there are a number of periods of time where the CO2 rises above that. And so what happens is that the technicians will extract data and put it in a table form that allows us easier access to it. And so what we can see here is that at the top, in the top table, that's carbon dioxide. And you can see going from right to left, going from less than 35 to 35 to 45, which is normal. The patient was in the normal range, just 1.7% of sleep time, and then was in the slightly elevated range of 45 to 50 for 80%, and then above 50 for 17%. And the reason I chose this is that by criteria that's typically used to identify hypoventilation, the threshold that's looked at is CO2 of over 50 for 20, is it 20 or 25% of sleep? 25% of sleep. So in spite of the fact that this patient had only 1% or 2% of sleep with a normal CO2, this would not have been flagged as hypoventilation. And so what we'll also do is look at the amount of time the patient actually had low oxygen. And in this particular case, the amount of time below 90 was exceptionally low and would not have raised any concern. And I bring this up because one of the questions is, can't you just do a pulse ox and have the patient on a pulse ox at home? And the answer is a very solid no, because you won't pick up early hypoventilation. Whoops. So from this, there are a number of questions that we began to touch on. Is it in fact acceptable to wait until the CO2 is over 50 for 25% of sleep. I would argue no, and that in patients that have neuromuscular disease, who we know are losing capacity, I feel that intervening earlier is better. And so one of the challenges is figuring out what is earlier. And so one of the things that we chose to do was take a different look at at hypoventilation. And there are a number of things beyond the carbon dioxide that go into interpreting a sleep study. One is the quality of sleep, and there's something called hypopnea, which is where you breathe at 50%, you have a loss of about 50% of nasal airflow. And that can foreshadow further breathing difficulties. When you have obstructive sleep apnea, that occurs, and typically goes along with complete obstruction or apnea. In neuromuscular disease, when you go into deep sleep, you can have hypopneas that are what we call non-obstructive. And the challenge is that when a sleep study is interpreted with the standard guidance that we use in pediatrics, non-obstructive hypopneas can be bundled in with obstructive events, and you can get a sleep study that ends up suggesting that you have your tonsils out, or see an ENT doctor, as opposed to considering starting on non-invasive ventilation. And so we wanted to try and clarify this a little bit better. And we came up with some criteria that are a bit more specific for patients with neuromuscular disease. And so I'll get to those in a few minutes, but what I wanted to talk about is a different approach for doing hypoventilation assessment. By far, the gold standard is doing a sleep study. You can monitor different stages of sleep and gas exchange through those different stages. But ultimately, what we're focusing on is the carbon dioxide value. And so one other approach is doing capnography, using a machine that just measures carbon dioxide and without the need to measure brain activity or sleep stage. And we're beginning to do this at home, and one of the advantages of that is that you, as mom or dad, don't need to come into the hospital and stay in the sleep lab with the patient. And frankly, the patient can sleep at home in their own bed, which in theory would give you a much better representation of a typical sleep night. These devices are able to record carbon dioxide and then can be downloaded and then evaluated to determine whether the patient crosses the significant threshold that would indicate hypoventilation. And this is an example of what we would get. The top graph is the entire night with carbon dioxide represented on the x-axis, and on the y-axis, amount of time in each phase of, with different levels of carbon dioxide. And so what you can see here is the peak spike is at about 50 millimeters of mercury, which is well above a typical normal range. And then what we can do is look in the raw data, and I've circled or outlined ranges that would get us concerned. In red, what we see is that the mean carbon dioxide value is just short of 50 millimeters of mercury, and the percent sleep time of the patient in a CO2 that's elevated is 31 and then 35, is a total of about 35% of sleep time. So that would certainly, in my eyes, warrant a consideration for a diagnosis of hypoventilation and initiating support. So, as I mentioned, we wanted to take a fresh look at hypoventilation and how we can diagnose it. And so we did a survey with a number of sleep-trained neuromuscular doctors and a number of us that take care of neuromuscular patients who aren't sleep-trained. And we did a 3-round process called the Delphi process, where we came up with criteria and then criteria based on what was available in the literature. And we decided to define hypoventilation a little differently. And because we know in patients that have progressive neuromuscular disease that their disease is by definition progressive, and if you have maybe mild hypoventilation that in the current standards wouldn't warrant intervention, that is something that will progress and will get worse. And so my opinion, and the opinion of many others, is that the earlier that you intervene, the better that you'll be able to support the patient. And so to that end, we came up with a number of different thresholds for carbon dioxide. One is 25% of sleep with a CO2 that's above the normal range. And then we had a different criteria of a shorter period of time with higher carbon dioxide. So in other words, if a patient was normal and then had a sharp rise in CO2 to above 50, and in our criteria that'd be for greater than 2% of sleep or for 5 minutes, that was felt to be to warrant treatment. And then we also had some definitions for oxygen below 90% for greater than 2% of sleep or 5 minutes, and then or a mean of below 94%. The other thing that we wanted to define would be is patients who are at risk of hypoventilation. So patients who are doing okay, but if they're challenged with an acute respiratory illness, they may need to, early in the course of their illness, be started on non-invasive ventilation. That would be, of course, in the hospital and not at home. And so we came up with 3 criteria that would indicate high risk of hypoventilation acutely. The other thing that we wanted to do was be able to give researchers who want to actually define respiratory failure as opposed to saying, when did a patient start BiPAP as an outcome measure. And it's important because starting BiPAP is an intervention, whereas diagnosing hypoventilation is describing a physical threshold. And the physical threshold is what's really important. This has advantage, and this has benefit also, because if we have an intervention and we have somebody that's on mechanical ventilation, we can do a sleep study or do capnography with these standard thresholds to define when somebody has recovered to the point where they can stop ventilation, as opposed to just saying we're going to stop ventilation because I think my son or my daughter has gotten stronger and is able to do well without ventilation. So a very objective way of measuring hypoventilation. So if you decide that when you've defined hypoventilation, the question then is where to initiate it. Dr. Newitt's going to go through some of the specifics in terms of equipment, but there are a number of different options. A typical approach is doing this in the sleep lab. And we're exploring a model of being able to initiate non-invasive ventilation in the office with settings that seem to work reasonably well, and then transitioning the patient to home, and then doing a capnography study to ensure that the patient is on adequate support. And we're doing this in part with, based on work that some of my adult colleagues have done at Penn, and what they have is the ability to initiate ventilation in the office, send the orders to the durable medical equipment company who will deliver the equipment to home, and then would then be able to transmit use data. So in other words, how often the ventilator is being used, but more importantly, what the quality of the use is. And this is an example of that. And what we have here is a minute ventilation, which again is the amount of air that a patient is able to breathe over a full minute. The higher number would be better. And so if you have, in this example, a situation where you have a day or two where the minute ventilation has dropped, then we can talk with the patient and try and identify what may have happened if there was a problem with the interface, the mask, or with the ventilator. And then with this, we can also record the pressures that the patient is being given and make sure that they're aligned with the prescription that we made. And then also look at the tidal volume that the machine is receiving back when the patient is exhaling to make sure that it's a reasonable value for the patient. Then what we can also do is we have the ability to look a little bit deeper and look at both the tidal volume, but also the ventilator can predict or calculate when there's a leak, either around the mask or perhaps through the circuit, which would indicate that the patient's not getting an adequate breath. And so with this information, we can then get a sense of how a patient's doing at home without bringing them into the hospital and doing a sleep study. So to finish, hypoventilation is very important to recognize, identify, and treat in patients with neuromuscular weakness. And then assessing hypoventilation requires a proper structure, proper paradigm to distinguish it from other forms of sleep-disordered breathing. And then treating hypoventilation is really important because it allows a patient to rest and recover at night and be at their best during the day, and hopefully give them the opportunity to reach their full potential. So I'm going to ask that perhaps we defer questions until the end, because Dr. Newitt's going to go over a complementary, further information focused on adults. Oh, here. Why is this not working?
Your mouse is on accident to display.
Oh,
Or whatever. Just keep going.
okay. Oh, there.
That one?
No,
Top one.
Top one, yeah.
Great.
All right. Perfect. So hopefully I can just add to that. My background is actually in pediatric and adult medicine, and my interest was doing my pulmonary and sleep training more on the adult side, with the focus of understanding patients and families that come from the pediatric world with neuromuscular diseases or that develop in adulthood, and how we can treat going forward. So I don't have any conflict of interest. What I'm going to do is take from the definitions that he's already described of hypoventilation. It's the same childhood, adulthood, and sort of focus more on the issues that come up during sleep with breathing, reviewing again in a slightly different way how we evaluate, more with an adult focus, and then how we can manage sleep-disordered breathing, and also put in a part about anesthesia. So starting with identifying breathing issues during sleep, just a review of the definitions Dr. Meyer went over. So sleep apnea is the condition we think of when breathing starts and stops many times during the sleep period. So it's not something that happens when you are awake. Obstructive sleep apnea is episodes where you have complete or partial blockage of your upper airway. So you can see here, it's hard to see from my angle, the air can flow completely through with normal breathing. If you get some collapse of the tongue or the tissues, there's some airway coming through, can create some snoring. This is the hypopnea, the decreased flow that can happen from the upper airway. Or you can have a complete obstruction of airway where no air can flow through, which would be an obstructive apnea. And then we also can have a central sleep apnea event where the airway is totally open, but the brain doesn't send a signal for the muscles to breathe. And then we have sleep-related hypoventilation, which is more of what Dr. Meyer was describing. So slow or shallow breathing that occurs during sleep that results in increases in carbon dioxide and decreases in oxygen levels. Disrupts the quality of sleep, resulting in sleep deprivation. And it's important to note that while we're awake, our brain actually plays a role in how we breathe. We remind ourselves to breathe. It's behavioral breathing. Compared to when we're asleep, and our brain is driven to breathe by levels of oxygen and carbon dioxide in the blood. And that sleepiness, that reaction can actually decrease with muscle function and can lead to more shallow breathing. And most severe, as he mentioned, during REM sleep, and we'll come back to that. So we have a cycle that happens, which is sleep begins. There's some degree of upper airway muscle tone relaxing, whether it completely obstructs or it's just the muscles being looser. You have then either an obstructive apnea, closed all the way, or decreased flow, the hypopnea, or you may have just muscle weakness without the upper airway closing, the hypoventilation he talked about, that then creates low oxygen and high carbon dioxide. The brain kicks in and says, hey, we need to breathe more. That stimulates us to wake up. Our airway opens, or we get a bigger breath. Our muscles are now a little bit stronger. They're awake. The oxygen and carbon dioxide levels try to fix themselves, and we fall back to sleep. And we repeat, repeat, repeat. As the system gets thrown off more, the muscles are weaker, the airway's too closed, we hit a point where we can't necessarily fix our oxygen level or our carbon dioxide, and that's what he was showing with the levels that remain elevated on some sleep studies. So what would you expect to feel? What does it mean to you guys or to your loved ones that have these symptoms? It can be anything. So nighttime symptoms often can be snoring, can look like someone stops breathing, they can feel like they're choking or waking up gasping for air, they're restless, going to the bathroom a lot. And during the day, we can see morning headaches, sleepiness, poor concentration or irritability, falling asleep with normal activities. And these symptoms can be from obstructive sleep apnea, or they can be from hypoventilation. It's really a crossover, and so it's hard to just hear symptoms and know what somebody has happening with their breathing at night. So what causes sleep disordered breathing in a neuromuscular patient is, first, the lungs are restricted. And when we say restricted, meaning they have trouble opening. So we have some condition that prevents them from fully expanding. It can be the lung tissue itself, but in our case, in the neuromuscular population, a lot of what we're thinking of is outside of the lungs, or extrinsic lung disease. So the lung tissue is working, but the pump is the problem. So either the muscles are weak, the nerves aren't sending the signal, or the bones and the chest are sort of twisted and aren't able to open as much, which can lead to hypoventilation. So just to give you an idea of what it may look like, this is a normal chest x-ray where you have the spine in the middle. All these gray lines through here are the ribs, and they're pretty symmetrical between the two sides. This is the diaphragm, the big breathing muscle at the bottom with the heart in the middle. So keep that as your picture of normal. And we compare to people who have some chest wall abnormalities. So someone who has scoliosis has sort of an S curve to the spine, and you can see the black is the air. So the space of the air has changed. It's smaller on each side, and with the twist, the ribs are apart, the muscles are either stretched or they're squished. They don't function as well. Similarly, somebody who has what we call kyphosis, so bent over more, sort of has a hump-shaped back, as you're compressed forward, has trouble opening up the lungs all the way, getting enough air in. And the third being not being able to move the diaphragm as much, so weakness. You only see a few ribs here. Normal is to see at least like 6 to 8 ribs or more when you take a big breath, and here we're down to 4. So this would be somebody who just can't get their diaphragm to move. So in these cases, we're suspicious. Looking at a chest x-ray leads to our question of, could there be some hypoventilation? There can also be upper airway issues that come with the anatomy. So you can have big tongue, big tonsils. So where you can see all the way through is very open airway compared to where your airway is completely blocked. You can imagine air flows through this one nicely, not so nicely if your mouth doesn't open all the way. This one shows the tonsils, sort of from hardly 0 tonsils to tonsils right here filling the complete space so air doesn't flow. If you're jaw isn't aligned. If it's too forward or too back, that can affect how air moves through when you breathe. If your jaw is too narrow, it affects how you breathe. If the palate, the roof of your mouth, is high, or there's a bony structure in there, that affects flow of air. If your tongue has scalloping, oftentimes that means it's wider than your teeth. The scalloping comes from the teeth making indentations. Just means your tongue is sitting in the middle of your mouth, and so airflow is going to be blocked by the tongue versus if it can sit below your teeth in the lower jaw, leaving the airway wide open. Neck size also contributes to how well the airway is pushed on. And nose structure. So in this case, the nose is deviated. So one nostril is smaller than the other, which affects airflow. All of which affects our breathing during the daytime, but more specifically at nighttime when we're sleeping and we're more at risk for having hypoventilation or sleep-related problems. There are also physiological differences during sleep. So sleep makes our lung volumes, what Dr. Meyer was talking about, the ability to take a big breath, it lessens it. So we lay flat, and now instead of gravity pulling our diaphragm down, now we're flat and the diaphragm is trying to go this way, but gravity is against it. We have a decreased volume of air. If you don't pull in as much air, it can lead to some upper airway collapse. So that creates more problems. We also lose our muscle tone in REM. So the deep dreaming sleep, REM sleep, is when all of our muscles are actually paralyzed except the diaphragm. So when we have muscle weakness, we use the muscles between the ribs to breathe. We use some up underneath our clavicle to breathe. Those are all paralyzed so that when you're dreaming, you can't be acting out, punching, hurting someone, hurting yourself. But it affects your breathing. Now, if only the diaphragm works, you can't get as big a breath, and it leaves you at risk for hypoventilation. We also have a decreased responsiveness during REM sleep. This is a natural human state that the brain is less responsive to changes in oxygen and carbon dioxide in REM sleep, down to 1/3 of how responsive it is to these changes when we're awake. So all of these things make us more susceptible to hypoventilation, especially when we have an underlying neuromuscular disease. So how do we evaluate sleep disorder breathing? There's ways we can start looking at labs, and in the adult world, we definitely take a sort of picture at looking at everything and pulling it together. So an arterial blood gas will measure the carbon dioxide level at that moment in the blood, which involves a needle and being poked in the artery, compared to a routine labs that you may have drawn to look at your kidney function, your sodium, your electrolytes, that a lot of people do routinely in the adult world on an annual or every other year kind of basis. So this is data that we may find in the chart when we see someone that gives us a clue, that carbon dioxide level is a little bit higher than we would expect. We can do breathing tests that will help us figure out the degree of someone's weakness in their muscles when they're awake, which will then give us a clue they may be at more risk when they're asleep. We can measure oxygen continuously overnight, as Dr. Meyer mentioned, with the pulse ox test that you sleep with on your finger. And we can do sleep testing. So just to look at the different systems before we go into the testing, so the obstructive airway can happen up in the upper airway compared to the brain not sending the signal, which is more central, versus the chest that itself doesn't take a big breath and is restricted, resulting in hypoventilation. So looking at our breathing test, the FEC is just telling us how big a breath we can take in. So we know, and that was some of the data he showed in the Duchenne history study, is once you get to this 50 to 60% of normal, we're at risk for REM sleep problems. Once we get below 40, we're at risk for both the deep REM sleep and then general lighter non-REM sleep for hypoventilation. When we do oximetry, this is a really, I guess, a severe example, I should say. So it does miss, as he mentioned, some of the more subtle early stages, but if somebody has a severe degree of hypoventilation. What you see here, this is the oxygen level on the bottom. So this line across here is 90%. Down here is 60%. And what you see is this pattern. This is heart rate on the top. This pattern of the person's awake, they start around 90. They drop down into the mid-60 range, stay there for at least 10-15 minutes, come back up, and then repeat. And if you notice, these intervals are every 90 minutes to 2 hours, which is about the consistency with REM sleep. And so we can deduce from this, without even having EEG data of sleep, that this is probably a period where the patient is entering REM sleep. Their diaphragm's the only thing working. They can't get big breaths. As they come out of the deep sleep, they then come back up a little bit. But the whole night is low. So in the examples he was giving of evaluating someone based on low oxygen or time less than a certain percentage, we would have this here. It would be diagnostic of some degree of trouble. Sleep apnea in itself goes up and down and up and down and up and down all night. So in straightforward upper airway sleep apnea, you don't breathe, your oxygen drops, you wake up, it comes back up. And so it looks very sharp and spiky compared to this sort of scooping pattern. So that's one form of test. We do then have in-lab testing, and in the pediatric world, it's used much more specifically, sort of gold standard still. In the adult world, we've started to get away from it a little bit. Depends in the area, the sort of neuromuscular related specifics of the provider. But when you come to the sleep lab, you get these things put all over you. If for anyone who's had one, you know, but you have markers on your head that are glued on. You have a cannula in your nose to measure flow of air. You have a sticker on your chin measuring its movement, 2 belts. You have EKG markers. You have an oxygen thing on your finger and things on your legs, and you're completely wired up. So I don't know how we get, I do it, but I don't know how we get kids to sleep like this, let alone get you out of your own bed in a foreign place, an uncomfortable pillow, and then we tell you to lay flat if you like to lay on your side. So while we get data, the data has to be looked at that exact moment, and the complication with the sleep studies is they are really meant to look a lot at just obstructive sleep apnea. So unless you have somebody that has a understanding of neuromuscular disease, the subtle differences between hypoventilation and sleep apnea get missed and wrongly diagnosed as sleep apnea. We also have home tests, which let you do it at home. It doesn't measure your brain. We don't know if someone's asleep or awake when the data comes back. But one form measures the effort of your chest moving when you breathe, the airflow in your nose, and a pulse ox. And the other one is more of a wristwatch that just measures the tone in the artery. The artery tone changes as we get into deep sleep, as we get low oxygen. Both of these, again, are at home. We don't know if somebody is sleeping, if they're awake, but you're at least in your own bed, you're more comfortable, and can miss the subtleness of sleep apnea versus hypoventilation. So the question is really, do you have to have a sleep study? The answer, depending on who you're seeing, may be yes or no. In, I think, our definition, the answer is no. You don't need to have a sleep study. You can be diagnosed with hypoventilation or sleep-disordered breathing without having a sleep study, using oximetry, looking at the pulmonary function tests, looking at blood gases or measurements of carbon dioxide, and treatment can be ordered accordingly. There's a lot of providers, unfortunately, that aren't aware of that, and so people, without visiting a center where there's some knowledge of neuromuscular disease, may go through a sleep study without really needing it, may end up with the wrong machine. So our hope today is sort of to present some awareness to that, so you and your families can ask the right questions of the people if you're going through this process. So how do we manage sleep-disordered breathing in someone with hypoventilation? So we have positive airway pressure, which is air pressure that's provided by a mask that connects to the motor and forces air either into the nose or the mouth. CPAP, which people say commonly, is just 1 degree of pressure. It's just used to really splint open, keep the tongue from falling back. It does not treat hypoventilation. So anybody with a neuromuscular disease, I would give caution if somebody wants to set you up with a CPAP. Bilevel positive airway pressure is 2 different pressures, one that breathes in and one that breathes out. So it's sort of, if you're lifting a heavy weight, you would drop it real quick, but if you have 2 spotters that are helping you on either side, helps you to get a big enough breath, is what we use for treating hypoventilation. Fun fact, center in Pittsburgh, it was invented here at the University of Pittsburgh. Can be used to treat sleep apnea patients, but only if they have failed or are intolerant to CPAP. But for the purpose of today, is really used for hypoventilation, to get you a bigger breath, to make sure that you're in sync with the machine, and can be delivered with either what we think of, people think of as a BiPAP machine or a ventilator. So sort of the more standard, smaller bilevel positive airway pressure devices look like clock radio size. They plug in, they don't have a battery. They are used for nighttime with a mask connected to them and can be put in different settings. Versus a ventilator style machine that has a battery, that has all sorts of bells and whistles that may be needed for someone if they're a little bit weaker or using the device in the daytime, not necessarily just for sleep. The settings that go into both can be comparable, and it's a little bit the nuances of the doctor providing it and what each patient needs determines which one of these you would need. Then there are masks galore. So we have nose masks, we have pillows that fit in the nose, we have one that cradles the nose, one that cradles and covers the nose, the one that covers your nose and your mouth, and one that puts your whole face in it. So the moral of this story is the right mask is the key. And it's not the same for every person. It has to fit. Do you have a skinny nose? Do you have a wide nose? Do you have a tall, narrow face? Do you have a wider face? So you really need somebody to know what they're doing when they pick out the right mask, because if not, the therapy won't feel good, and you won't want to use it anymore. We haven't touched a ton on daytime support, but I just wanted to add in, when people get to the point they're not taking big enough breaths during the day, the same machine, the ventilator-style machine that is used at night for one mode with a mask, can also be switched over to what we call mouthpiece ventilation. Sometimes people more call it sip ventilation or sip and puff, where you have a tube that comes off with a little mouthpiece, and it just sits there and you use it as needed. So you literally sip on it, and it blows air, and it helps you get a bigger breath. So this is something, as we have people who need more support in the day, that feel more short of breath, whose carbon dioxide levels remain high, whether they're awake or asleep. We use this in the day, and we put the mask on at night to overcome the hypoventilation. So the last thing to touch on before we open up to questions is just breathing challenges with anesthesia. So I think of anesthesia as a medication-induced sleep, right? So all of what we just talked about with anesthesia is going to happen because we're giving you medicine to put you to sleep. So it exacerbates it. So we have a decrease in our respiratory rate, how many breaths we take. It decreases the volume of air in each breath. Depending on the medicine they're using, it is either going to decrease or paralyze the muscles, decreases the brain's responsiveness to changes in the oxygen and carbon dioxide. So the question is anesthesia safe? Unfortunately, in life, most people need it for something, whether it's emergent or not. And so I think we have to look at each situation individually, but sort of the questions to think about are what type of anesthesia you might get. To define it, we have moderate sedation. Some people call it conscious sedation, where patients are actually awake enough to respond if we ask them a question with yes and no kind of answer. They're usually breathing on their own, maybe with a little oxygen or something, but they're the one taking the breaths, monitored with a heart rate and a pulse ox monitor, but not necessarily remembering, but at least awake enough to be moving and to to respond. But you can imagine if we decrease your consciousness, we're decreasing your muscle function. If your muscles are already risk of, with sleep, not getting a big enough breath, the moderate sedation could take your carbon dioxide from normal to way beyond normal, where you're at risk of really being in trouble and not waking up. General anesthesia is what we think of as a complete state of unconsciousness. So we give medicine to someone, they don't respond, they're not aware, they don't feel pain, they can't cough or gag, and they require a breathing tube or something with a ventilator to make sure that they get breath. So this is very deep sleep versus sort of consciously awake sedation. In the world of the neuromuscular patient, and this we talked about the ped side, there isn't a ton of moderate sedation, but as you enter adult world, you're faced with things like colonoscopy, starting, if you're lucky, at age 40 or 45, every so many years. People need, if they have any sort of upper belly issues, they need an endoscopy to look at their stomach. That's conscious sedation. For some people, dental work, they want some degree of conscious sedation. All of these things are going to affect your ability to breathe and put you at a risk for hypoventilation. So my recommendation, is it safe, is make sure that the anesthesiologist you're working with is knowledgeable, that they understand that you have a muscle disease-related problem and the things that could come of it. Specifically for RYR1, make sure they know the risk factors associated. So I know there's a malignant hyperthermia talk as part of this. That's a big risk with some of the anesthetics that they use. Make sure they understand, even though you may be walking, talking, moving, whatever they use as their criteria for somebody for hypoventilation, that you are at risk for that because of muscle weakness, and that you may have altered responses to any muscle relaxant type medications that they give you. And if you are using non-invasive ventilation or positive airway pressure therapy at home, plan ahead and bring it for recovery, because when you are awake, you're awake, but you're still sleepy. Your muscles are still taking time to get the medicine out of their system to breathe normally. And consider overnight admission after anesthesia, depending on the procedure. So for people who don't have muscle weakness, they may say, oh, you just come in same-day surgery to get your knee replaced, your colonoscopy, you go home. For people who have significant breathing issues, it really can be dangerous to go home without monitoring or using the right machine and positive pressure afterwards for at least 24 hours till the medicine is out of the system. So I think with that, we can open it up to questions. There's the city of Pittsburgh, for those of you who didn't make it downtown to the point, with the fountain that's under construction this year. So, somewhere there's a microphone we're supposed to use. Does anyone have any questions for either of us? We can just open it up.
If nobody else.
Pass the microphone so that recording people can hear the question.
Thank you for that talk. I've got two questions. One, for 6-year-olds, generally speaking, is there a kind of mask from that list that you listed that's more tolerated, is the first question. Second question, so my son, who's 6 years old, used to snore a lot. We spoke to our pulmonologist. She recommended that we did this, use this steroid-based nasal spray, and now he doesn't snore. But there was concern about the adenoids and talk about removing them. Would you recommend that even if his sleep study comes back that everything is looking good, it's still a good idea to remove adenoids anyway, just in case it's exacerbating the overall problem?
At least in my practice, the decision of removing them usually comes from the surgeon with advocacy from, pulmonologist, and they often need some type of evidence that they're causing a problem. So if you have a normal sleep study and you're not dealing with lots of pharyngitis and upper airway bacterial infections, then the recommendation would probably be to not remove the adenoids, because it's not a simple surgery, even though it's, it's not like, it's a relatively straightforward surgery, but it's not without complications. Complications are greater than removing the palatine tonsils that you usually see in the back of the throat. As to an interface for a 6-year-old, the approach that we usually take is we bring in a box of nasal interfaces and sort of look at the patient's nose and try and find an interface that seems that it could fit over, and then try and fit it on the patient, and then see if it seems comfortable. And a lot of it is a bit of a crapshoot, to be very honest. And if you try if you try an interface, the first one that you get when you have to use non-invasive ventilation and it works, consider yourself lucky. So I can't give you a really clear, solid answer other than if your son's not comfortable with it or it's leaving sort of pressure marks, then to try a different interface.
Yeah, thanks for that. I was asking because in the first few months of his life, there were only a few kinds of masks available in our country, and I ended up literally holding it on his nose and like falling asleep myself, holding it in place because we struggled so much with the mask. So I was thinking, if there's like a universally accepted mask to bring it back, but it sounds like that's not the case.
They really only make in pediatric sizes nasal style masks because we want children, if they're going to wake up vomiting or etc., that there's nothing covering their mouth from a safety standpoint because they're not always able to get it off by themselves. Additionally, you want them to be able to call out if they're in trouble and so forth. So most pediatric sized masks, small enough for a face, are going to be in the nasal range. And they come, I put this back up here because you can decorate them in different patterns, which the adult form don't let you do. So this kid has like a giraffe pattern on. But most of these other styles you don't find unless you have hit the child at an adolescent age or they have bigger facial features that they can fit into like an extra small kind of adult mask. It's one of the worst limitations that we have in the use of non-invasive ventilation. And I agree with the adenoid question, which is if your sleep study has normal oxygen, normal carbon dioxide, and no sleep apnea type flow events, the risk of the surgery is probably higher than the benefit. And as we grow, those adenoids, if they stay the same, become less of a problem as the airway gets bigger. You want to pass the microphone over?
Oh, hi. So my son is currently doing pretty extensive CPAP trials right now, like 8 hours a day via his trach. I spoke a little bit about CPAP. And sometimes he'll fall asleep during that, and his alarms go off, his respiratory rate goes up, and there's always this conversation of like, well, we can't keep switching him to, his night settings every time he takes a nap during the day. But is he being underventilated every time he falls asleep on these CPAP trials? Like, should we be switching him to a different mode when he falls asleep per your entire discussion, or?
In your particular situation, it's in the process of de-escalating
Right.
and coming off of ventilation. And so in theory, the answer should be he should be doing perfectly fine on CPAP.
Sleeping or not, that's what you're.
Well, and certainly if you can, the ideal situation would be to put him, switch him from CPAP back to ventilation, which because of his setup shouldn't be that
It's not,
that big of a deal.
Right, yeah.
But the one thing that I do want to make clear is that the typical diagnosis, when you make a diagnosis of hypoventilation with high CO2, the only support that should be considered is bilevel positive airway pressure and not CPAP. And the point I was trying to get across in this, and the way that sleep studies are often interpreted is that there can be a misinterpretation and a suggestion that you're dealing with obstructive sleep apnea when you have a completely open upper airway, no large tonsils, no snoring. And the issue is that if you put somebody on continuous positive airway pressure who has hypoventilation, you're not ventilating them. You're applying pressure to keep their upper airway open, but you're not helping them breathe. And if you have hypoventilation, that's defined by an inability to bring in the oxygen you need and remove the carbon dioxide. And so the only approach to treating that is using bilevel positive airway pressure or ventilation.
And so, to that point, should we be getting like blood gases after these trials if he is alarming, or?
No, that they're able to monitor his end-tidal carbon dioxide, so
Yeah.
that should get you what you need.
Okay, then if that's fine, then it's,
Yeah.
okay, great.
Hi. I was just wondering, both in your adult and your pediatric neuromuscular population, have you seen in your collection of patients, some of them have the need to take, particularly during their waking hours, during the day, just take deep breaths just to kind of, and again, I'm wondering if you've seen that. If you do, what would be the cause of that? Are they collecting too much carbon dioxide, not with weak muscles, or? The reason I ask is my granddaughter, who's 8, and my son, who's in his 30s, both experience that. They just periodically just need to take a deep breath. They both have RYR1, and they just need to take a deep breath periodically. And it just says it, I don't know, it's not like they're short of breath to begin with, but it helps them reset whatever's going on, whether it's high or low O2 or CO2. I don't know. I'm just.
Are they aware of it, or just
Yes,
somebody
they're very-
watching them is aware of it?
Well, my son, who's in his 30s, is aware of it. And when I ask him, why are you doing that, he says he just feels the need to do that. And my granddaughter, who's been doing it, she's 8 now, but she's been doing it for a couple years. And I would ask her, she doesn't know why she needs to do that, but she's like a sigh. But, she's taking a deep breath, and she's not aware why or even that she's doing it.
Yeah, so sigh breathing is natural to humans, especially in the behavioral component of breathing, which is our brain actively telling us while we're awake to take a breath. Some people get super focused, reading, kids playing games, they actually forget to take a breath, kind of look like they're holding their breath, and then all of a sudden their carbon dioxide goes up, the oxygen goes down, the brain kicks in and goes sigh to fix it. That can be one reason, is sort of the behavioral side of breathing gets adjusted or doesn't continue. For other people, they naturally breathe a little more shallow, can be muscle weakness related, can be behavioral, and so every once in a while that sigh breath is the same thing, sort of just making sure levels are in check. That was sort of how I would answer it.
That could certainly be it. The other could be that you said that they feel better afterwards?
My son's a very bright person, highly educated.
Yeah.
It's not like he's saying, oh, I'm feeling this or feeling that. He just says, I feel like I need to do this. Not necessarily that he's feeling short of breath.
Right.
And my granddaughter has no explanation. And I was just wondering if you're seeing that in your neuromuscular population. I mean, I know everybody sighs periodically, but I was just wondering, in your collection, you have a much larger population of people with a particular kind of disease. Is that a common phenomenon that you're seeing or not?
It's something, I agree with what Dr. Newt was saying, that can be a normal pattern of breathing, and there's a physiologic reason for why it might be necessary, and that is if you're breathing very shallowly. The tidal breathing is about 5 to 10% maybe of the total lung volume. That means that the remaining 90% really isn't used widely. And if you're not expanding your lungs, then the lungs sort of deflate a little bit. And so one of the things that we do when we get up in the morning is we yawn, we stretch, and we usually take some deep breaths. And what that does is that re-expands those collapsed or atelectatic portions of lung, and it can make breathing a little bit easier. I liken it to, if you've been sitting down for a while, getting up and stretching and, moving your muscles. I wouldn't consider it bad at all. I would actually consider it probably, you said that it seems to me that they don't really think that they don't consciously say, I'm going to take a deep breath. It just sort of happens, and that may be their body, sort of their body saying it's time to stretch and take a deep breath.
Yeah, okay. I've just been muddling through this whole R-Wire1 thing, and so many different things come up with, my family members who have it. And we're always going, gee, I wonder if that's related to the R-Wire1, or is that something else or whatever. So that was a phenomenon that I'd seen in two of the family members. Thought you might have an association there or seen that, but.
It certainly can be. As you get weaker, though, the sigh breath is what you lose. So as your muscle strength weakens, especially as people become more twisted from muscle weakness so the spine can curve, or just aging, the sigh breath is what becomes harder to get. And so we end up breathing faster, more shallowly, because we can't get that big expansion. So it's certainly not associated with severe degree of dysfunction.
Thank you.
No other questions, I guess it's break time. Oh, another question.
Hi. Couple of questions. One was about hypercapnia. Are there anything on the market where you can monitor that at home? I know the hospitals have those nasal, I think it's in the cardiac wing, but they have the nasal cannulas that have the little the little thing that can measure carbon dioxide on them. Is there anything like that at home? She sometimes still gets up in the morning with bad headaches. She can tell the difference between like when her headaches are really, really bad, where her head is swimming. We know the CO2 levels like up there. But we don't have a way to, just keep an eye on it, measure it from time to time. And I didn't know if there was anything on the market that we can measure it at home.
Yes, but it would be something that would need to be medical grade and go through a durable medical equipment company. So the pulmonologist or the person that's managing the ventilator should be able to request one. Then the question is how to present a good argument to the insurance company to pay for it. And you could certainly say, my ventilatory needs are variable and we need to make adjustments routinely, and we need the feedback from a CO2 monitor, and that may or may not be enough to be able to get it approved. The problem is that getting a good, reliable result can be a bit challenging.
That's what I was going to say. We are not at the accuracy with home devices for carbon dioxide like we are with oxygen. So it's very few and far between, and how it's measured most of the time is through the air we breathe out if you have somebody with a mask or on a tracheostomy tube versus like a signal that you could put on your finger. The science, the technology, the accuracy is all over the place.
Okay. And the second question was about anesthesia. It's very hard to intubate her. And anesthesia is getting more and more risky for her. For minor things, or like non-emergent thing, like, is it possible for them to do like maybe a spinal something, like to keep her, even if she's awake during it? Is that an option for her, a plausible option for her?
Yeah, it all depends on the procedure, but especially in where you are, if you're at a more tertiary center where there's different trained types of anesthesiologists, like I've had patients go through pacemakers, defibrillators with just local, like sort of spine or nerve block to not have to have anesthesia. Anything that's going to go into the mouth, like an endoscopy or a bronchoscopy, you need more sedation for comfort standpoint. Anything lower limb, you definitely can do more of a spinal block if there aren't other sort of contraindications for it. But that's usually anesthesia will look to what are our options that are not less invasive, less systemic with blocks and so forth.
Okay.
Yeah.
Waking up with a headache using a BiPAP, what is it a sign for?
Underventilation.
Starting with bad mask fitting.
Oh, I'm good.
So if you have morning headaches, in theory what is happening is that if you have high CO2, the blood vessels in the brain will dilate in an attempt to try and remove CO2, but they're dilating in a closed space, which ends up causing a headache. And so if or when the CO2 normalizes after you wake up, the headache should go away. But transient morning headaches are very commonly associated with hypoventilation, would certainly make me worry about the ventilation not being adequate.
The alternative could also be positioning. So some people fall asleep with their neck really far down, which closes off the airway. So it's not the machine, it's more positioning.
More like up.
Up, that also can do it. Overstretching, if somebody is twisted in the wrong way, you end up with pain that pulls on the neck. So more structural headache, if you know that first and foremost problem is make sure the carbon dioxide, the breathing is okay, but then beyond that, it can be more structural related positioning and so forth that can cause morning headaches too.
So the thing is, she's sleeping with an open mouth. It's a nasal, but she doesn't want to go with a mouthpiece. So it's like kind of
Maybe a chin strap?
chin strap in.
The one other thing I want to say related to surgery is we know all about the importance of safe anesthesia and a non-triggering anesthetic, but the postoperative period is also very important. For anybody here that doesn't have RYR1 who's undergone surgery or some type of anesthesia procedure, one of the things that ends up next to your bedside when you wake up is an incentive spirometer, and a nurse telling you to breathe through this every 10 minutes. And the purpose of that is to help you re-expand your lungs. And if you don't have the muscle strength to do that, then you need an alternative approach. And the approach that we usually use is to use a cough assist or some type of lung volume recruitment procedure. And without that, the recovery time can be longer and a bit more rocky.
Can I just ask a quick question on that? Is that a standard procedure after every surgery to have the cough assist, or is there a specific situation?
At least at our institution, it is. They're not sort of codified, post-operative guidelines that are everywhere, but most standard of care documents will have some language about that.
I think that's a good answer in the pediatric side, especially if you're at a pediatric center with knowledge and experience of different degrees of issues. When you move to the adult side, if you're at a main tertiary hospital in Pittsburgh, for example, our 3 top, one has cough assist, one doesn't. Not even a single cough assist in the whole hospital. So those are my patients. I tell them don't go there because they don't know how to use it. If you're at a more, in the adult side, more local community kind of hospital, you probably aren't going to find cough assist, and it's not going to be a well-known thing.
Sorry to cut into the break, but
Yeah.
it's a break until a minute. But all joking aside, we're doing the next session, so if you guys want to get out and stretch or get something, feel free, and we'll start in a few minutes.